I'm Kathi Stringer. I'm with the California Director, or actually Director for the California Network of Mental Health Clients. And QIC was very gracious and let us use their equipment today to do a quality improvement training. Do you think maybe it would be okay if we went around and did introductions first? Find out who's here, or is that...
Sounds great.
Okay.
And also to check in and make sure everyone can hear.
Sure. That would be a good idea. Maybe we can start with the LA office with the introductions here.
I'm Marilyn Holly, one of the attorneys in Los Angeles at PAI.
I'm Stuart Seaborn, also an attorney at the LA office of PAI.
I'm David Chan. I'm a summer law clerk here at LA PAI.
And Lakita, I'm an advocate here at the LA office at PAI.
Don Small, law clerk at LA PAI.
Elaine DeRush, a client, the California Network of Mental Health Clients and the Los Angeles County Client Coalition.
I'm Pamela Liu, I'm a staff attorney at Protection and Advocacy.
Christina Cabrera, family member and photographer.
Which office should we go next?
How about Sacramento, Oakland, and San Diego? In that order?
In Sacramento, there's Agnes Lentz with the Office of Patient Rights.
You want to speak? And Kathi Stringer from the California Network of Mental Health Clients.
And in Oakland, Dan Bursavich, I'm an attorney with PAI.
Jim Fields, I'm a trainer with the Peer and Self-Advocacy Unit with PAI.
Yeah, hi. I'm going by a new nickname this year. It's my email address, Enrique2005@earthlink.net. I'm from San Jose. I just feel like I'm somebody that's hit some sort of invisible glass ceiling and I'm still trying to define what it is. So I turned cultural competency on its head or sideways. I'm talking like race-gender matrix as a tool to define relations, because I'm finding all kinds of, like invisible, whether semantic or otherwise, just like barriers to getting what I need.
Okay, well, welcome.
And I'm Leah Fagundes, and I'm a peer counselor at the Rights Resource Center. I'm also a California Network.
And I'm Bill Brayfield. I'm the Marin County Patients' Rights Advocate.
And in San Diego, Willie Collins, California Network of Mental Health Clients member, and also working for the Health Advocacy Project with PAI, which has just recently been folded into the PSA unit. So hello, teammates.
And good afternoon, I'm Connie Wing, CLA at San Diego County. Welcome.
I'm Karen Rotha from United Behavioral Health. I'm our Quality Improvement Manager.
Well, it's back to me, right? All right, well, let's get started. Hopefully we can get through this in less than 2 hours. I hope so. What I did is I tried to do PowerPoint. I just stuck it on paper since I didn't have a projector or anything, so that should make it a little bit easier. This quality improvement manual is the first of its kind. It's, as far as I know, there's never been anything done like it before, and it started out that I went to a QIC meeting, and most of the people would go to the meetings, they wouldn't understand why are we here and what are we doing, and we found out a lot of parents were venting and trying to wing it, and after 2 or 3 sessions, they would quit coming. And when I asked for a QI manual, they said, what the heck is that? We don't know what a QI manual is. And a little bit about me, I came from, I was self-employed when I was 23 years old, and I built parts for medical, automotive, and I think when I was 26, I was a key supplier for Hughes Aircraft. We supplied parts for their El Segundo electronics division. And it was important for us to have a quality control. And part of our quality control, we went to a MilSpec I-45208A and also a MilSpec I-105 sampling standards. And what all that means is we had a very rigorous QIC operation. So the first time I went to a QIC meeting, and they didn't have a QI manual. I was like, how can you have a QI meeting without a QI manual? It just didn't make sense to me because we had manuals, and every time we changed them, we always had to revise them. And we had to say what we did and when we revised them. So none of this made sense. So we started plugging along, and I started going to the state website and looking through their state strategy, and also reading a lot of the memos they had, and actually it was starting to come together. It took a long time, but we started to come together. So let's go ahead and get started with this. I think I've said a little bit about myself and everything. So, like I said, this is our first manual. And before we go into the manual and what QIC is Quality Improvement Committee. That's what that means. Before we get into the complexities of QIC, I would like to discuss and give us some tools what we can use before we walk in the first meeting. After all, if we wanted to walk in the QIC meeting, we want to feel like, lack of a better word, a little bit honored.
Hold on just a second. This is Dan from Oakland. Could someone from LA zoom in a little bit so we can see?
Is it this, maybe we can refer to where it is in the manual.
Yeah, I was just going to do that. Right now, look in your manual, page 5. This is page 5. This is kind of helping me out, too, so I can see what's going on. In fact, I should have my own manual in hand. I would like to start this out by the first couple of pages, round-robin reading. Can I get somebody to volunteer to read this page 5 for me? It says it much better than I can say it, that's why. Sure, go ahead. And your name was?
Elaine.
Elaine, thank you, Elaine. What's your face? Thank you.
Forward by Kathi Stringer, Director of the Far South Region of the California Network of Mental Health Clients. Why? Oftentimes it seems people that come to quick meetings are lost or don't have a clue as to what's going on. In these cases, members, visitors, may drop out due to the frustration from lack of improvements, or many feel like their presence doesn't make a difference because nothing ever changes, or if it does, it is at a snail's pace. Some feel like meetings are the place to vent and little else. However, we are encouraged with this new quick manual, the first of its kind, to get mental health service improvements on the move and into action. When? During a network regional meeting in Orange County, California in 2004, the suggestion of a quick manual was voted in by the California Network of Mental Health Clients as their 2004-2005 regional project for a statewide tool, reference, and guide to assist quick members to have meaningful and knowledgeable participation in quick meetings. Who? You. You can make a difference. Even if you read the contents of this manual and support your fellow members with a raise of hands with an informed choice, you will help make the future brighter for everyone. How? Show up at the monthly meetings. Your presence is a vital first step. You can also meet with other quick members to discuss issues of concern during the week. Between quick meetings, you can hold town hall style meetings to brainstorm on how to improve upon the foundation of this manual. Remember that this manual is only a starting point. The possibilities are as endless as your imagination. Hopes, goals. To change. Nothing changes if nothing changes. Set your sights on well-defined goals and keep working towards them. When you feel discouraged, remember there is always more than one way to get things done. This quick manual is only a starting point to get you up and running.
Thank you, Elaine. That was great. And like she did, when she read this is the first one, and there's lots of room for improvement. So far, this is just coming from my perspective, my experiences, and anything we can go from here is totally welcome. Now let's go to
Kathy?
page 6. Yes.
Kathy, this is Willie in San Diego. We had some people from Imperial show up. I wanted to just interrupt and have them do introductions.
Oh, by all means. Sure, Willie.
Thank you. You can just speak into and say hello.
Hello, this is Michelle Stanford with Imperial County. Nice to be here. Hello, my name is Andrew Gaxiola. I'm from the Recovery Clubhouse in El Centro.
And my name is Hilda Donnelly, and I'm also with Imperial County. Glad to be here.
Is that it, Willie? Well, I'm not done with you yet, Willie. Now that we're on page 6, do you think you could read that for us?
Yes, I could.
Thank you.
We'd like to get you up and running quickly as possible. In order to do that, this manual is split up into several sections. The more in-depth information is placed at the end of the manual to help make written consent easier to understand and to aid in the learning process. We make ample use of examples, charts, and illustrations. Source. Part of the material in this manual was extracted from the State Department of Mental Health website and from the State Quality Improvement Council and other policy and procedure manuals written by state employees or contractors. Included are flowcharts and step models written especially for this manual, along with flowcharts from the State Department of Mental Health. The references are in whatever they call those. Brackets, there we go. Remember why the first Model T automobiles looked like compared to today's cars. Similarly, this is the network's first QIC manual, and this manual is just the beginning. There's a great deal of room for improvement as other members get excited and involved. Optimistically, individuals with different perspectives will add their contributions, and the QIC manual version 1.3 will continue to be revised. We hope this manual will inspire you and stir your imagination to the endless opportunities for performance improvement. Our #1 goal is to ensure safety, avoiding injuries to patients from the care that is intended to help them. You are a pioneer in developing and beta testing the network's first QIC manual. Congratulations and welcome aboard.
Thank you, Willie. You did a great job. As Willie said, and when he was reading, he said that this would be continued to be revised, and he said version 1.3. Well, we're already on version 1.5.1. After today, it's going to go up again. And you'll see why, because we're going to be bouncing around a little bit. Okay, now we're going to bounce over to page number 18, 19, and 20. So it's a combination of those 3 pages summed up in one. How many people have heard the Hardy Boys? Okay, detective group, right? We're always going out looking for mystery, just find mysteries. Well, what we're going to talk about now is root cause analysis. And the example I'm going to give you is the same example that a consultant for APS Healthcare gave as a consultant. And the way they started it out was they showed a spike in hospital admits one month, and they couldn't figure out why. They said, why else are we just going like this? All of a sudden we went like this and on again. And they wanted to know why, so they thought they would use the root cause analysis. Root cause analysis, what it does, it asks a series of why questions. Usually the magic number is about 5. So the first question would be, why was there a spike for that month in admits? Well, they got to the bottom of it, they printed out the data, and they moved some things around, and they found out that the patients were coming from the rural zip codes. What they found out was, after they found out it was the rural zip codes, they went in and they did some more investigation, and they found out a particular service, delivery service, was taking the patients to an outpatient clinic. And so that would be our third why question. Why does this particular service, who's taking people to an outpatient clinic, why are those particular consumers ending up in a hospital? So this is really mysterious. And so they did some more investigation. They found out that these guys weren't getting paid runtime. They had no motivation. It turns out the county had done reassignment of pay codes and pay numbers. And so a lot of times when they'd send in their invoice, accounts payable would kick it back. And they did, really didn't care if they showed up or not. So these people ended up hospitalized because they weren't getting their medication or they weren't getting their therapy or whatever. So the last why question, and by the way, I would like to, before we get to the last why question, usually root cause analysis focuses on procedures and policies and not so much as the individual. We're not looking to blame somebody as we are to fix the whole process. So right now, we're looking at the 5th why question, which is, why did they not get assigned the right code. Well, they found out there was some kind of a gap in the quality, and the way they assigned the codes from one to the other wasn't double checked, or there was some reason it just wasn't correct. So what they did is they did a corrective action. They made forms to double check one form to the other, and they had other ideas to fix that. So what they found out in 5 white questions all came down to somebody getting all these hospital admits. Somebody didn't get the right pay code. Who would have figured we would have had a spike because somebody didn't get a right pay code? So by asking a series of why questions, we were able to do that. After hearing that on a tape, I think Marilyn from the state quality, she sent me this tape, and that's the example I used, and I thought, hey, I want to try this myself. I want to find out if this thing works, you know. So consequently, I got an email from a guy. He said his daughter was inpatient in the hospital. He says he needs help. It feels like she was getting over-medicated, and she wasn't getting help. So, you know, after they signed off and got me involved, I called the hospital, and I said, I understand that this particular client that I'm representing right now was involuntarily medicated. Can you tell me why that happened? Well, that would be my first why question. Why was she involuntarily medicated? And he said, well, you know, she was running up and down the halls calling 911. All right, I said, and I talked to the, I think it was the nurse at the time. I said, well, second why question, why was she calling 911 running up and down the hallways? And they said, well, we don't know. And I said, well, you don't know. So I'm still stuck on my second why question, you don't know. Well, I said, was there anything that precipitated that? Does anything happen within the last hour or so that might have made her go off like that? And by the way, this goes on all the time. I'm sure you know this. And they said, well, we don't know. We don't see anything in charge. So then I talked to the charge nurse. She didn't know. So then I talked to the social worker. Social worker didn't know. Talked to the supervisor. So then I called back and talked to a hospital administrator. I'm still trying to get down to my root cause analysis, you know, being one of the hardy boys, adapting into the committees. I'm not going to let this go. Well, he passed me off right away to the risk department. The risk department says, well, we don't know. And I said, well, don't you think it's important to find out why people are getting involuntarily medicated and why they're running up and down the hallways? Wouldn't that be an important component? And she says, well, yeah, it would. And I said, well, just for the heck of it, because I knew a little bit of the story, what was going on. But I said, did anything happen around her medication that morning? Because I had a little bit of insight. They said, well, yes, it shows that she refused her medication. I said, okay, and why did she refuse her medication? Come to find out, she was on Depakote, and I think the magic number was 500 milligram, and she was taking it twice a day. She was getting sick, she was throwing up, she was laying in her face her own vomit on the floor, and she was freaked out about this high doses of medication. Well, the doctor had told her, she said, look, she said to the doctor, I can't do this anymore, I can't take this stuff. Doctor says, well, you're going to have to. And of course, you want to be treatment compliant. You know, if you're not treatment compliant, you get a capacity hearing, a Reese hearing, and next thing you know, you're set up and you've got a conservator and everything else. You can go down that road. So she wanted to be treatment compliant, and come to find out that he said, all right. So she suggested 3 times a day. He said, okay, we can do it 3 times a day. We'll try this 3 times a day, get you your dose, and then you won't, maybe that won't make you sick. Well, that was the evening before. The next morning, she walks in to the med counter, and guess what's waiting for her? The same usual medication. She says, I'm not taking it, right? So the nurse probably said something like, well, that's your right, you don't have to take it, but you know, it's going to keep you here longer. We've all heard this before. And it's going to keep you here longer, you know, we can get a raised capacity here, and you could be forced to take it. Now imagine what's going through her mind. I could be forced to take something that makes me sick, that makes me throw up. I'm trapped. I have no advocate. Would that be enough to make somebody run up and down the hallway and call 911, you think? Maybe, huh? Especially if it makes you really sick. So I guess, but it took her a whole hour. It wasn't like she was impulsive. She had some impulsive control. I mean, she actually thought it out. So an hour later, that's when she went into her little spiel. So the thing is, we have to ask the next why question. And I'm not really savvy to the clinical records because I didn't look at them. But the next why question is, why didn't the doctor's communication get transferred into the clinical notes and the progress notes and the multidisciplinary notes, or the doctor's orders? Why wasn't it? Nobody knows. So if I would suspect by doing this root cause analysis, when we got to the bottom of it, we could look for corrective action. We could suggest that there would be in-service training on charting the clinical notes when a doctor makes an agreement And also, well, I guess that would be it. And I'll also put it in the doctor's orders or have some kind of a tracking when a patient makes a request like that. But we never got that far. But you can see how root cause analysis helped us find out why this girl was doing what she did. And nobody in the hospital knew this. And I had to go through the mystery manager to find out. So does that make sense with root cause analysis? And this is a simplified version. This could get as complex as anything else. You know, you can make it very complex and it can get complex, but I want to keep it simple because it's a nice tool the way it is. Okay, that was pages 18, 19, and 20. Pages 21. Let's talk about reports. A lot of times when people are in a QIC meeting, they get reports. Sometimes these reports are very convoluted. A lot of times we're expected to believe whatever they tell us. I've seen some reports get passed out that says, you know, we got an A. Yeah, well, where'd you get the A? I mean, what makes up an A? Well, that's just how we figured it. Well, what's your formulary? You know, how did you come up with that? And a lot of people, they don't know. They just believe what's put in front of them. Well, you know, I got to the point where I didn't want to believe anything in front of me anymore. And I wanted to make it simple. Something simple where you could see a report and make sense of it, that you didn't have to, you know, hand it to an engineer and tell me what it says. And what I found out, every report has data, okay? Usually two sources of data. Well, the first source of data would be, well, I'm going to get to that in a minute. Let me just talk about what's in a report. First of all, every report starts out with a concern. I have a concern. There's 150 grievances this year, okay? So that would be the starting point, concern. That concern would be backed up with data. Okay? Two sources of data preferred. And once we get the data in its raw form, and I'm going to explain this more, I'm just going through it real quick, we have a performance measurement. Once we execute the performance measurement, we're going to have an indicator. Indicators are preferred to have it this year's indicator and last year's indicator. That's the only way we can measure for improvement. If we only have one indicator, we don't know if we're good or bad. And the idea is quality of improvement going up, right? And then baseline, what
So
that means
Kathy,
is
this is Sacramento.
Yes.
Our page 21 doesn't look at all like we think your page, it doesn't sound like what you're talking about, and we really can't see what's up there. It's very blurry.
Okay.
Page 20.
So I'm not sure if...
Page 21, this is like I understand what you're saying. The page 21 that you have is the manual page. This is more like a PowerPoint, the way it looks. Can you see it a little better? It looks like somebody might have zoomed in on it. And I'm going to talk about what these are. I'll go through them again real quick, okay?
The page starts at looking at data. Is there a concern, question mark. That's the top of page 21.
Right, that's your page 21. My page 21 is it looks like more like a PowerPoint. It looks different. And right now, it's mostly me talking. You don't even have to really look at your manual at this point. Just kind of listen to what I'm saying, and that'll probably get you through it at this point. Okay, so starting again, every report starts out with a concern. Okay, I have a concern that, whatever you're concerned about with the report, every report should have data. At least two sources of data preferred. That makes the report relative. The next thing we need to do is do a performance measurement. I'll talk about that in a second. Then after the performance measurement, we're going to get indicators. Now, I know I'm losing some of you guys, but don't worry, I'm going to make this real simple in just a minute. Baseline would be a starting point. Benchmarks the goal. That's where we're going with it. Okay, now I want to break this down. The first one, concern. Let's say we're looking at a report and there's 150 grievances. You might, and you always frame it question with, I have a concern that. That would be the way to do it. In any kind of a committee, any kind of a board, I have a concern that, and whatever your concern is. And then you look at the data, and like I said, you frame the question with, I have a concern, there's 150 grievances. Okay? Once you say that, then you're going to need two sources of data. Data one, and I'm going to go ahead and start drawing now. Can you guys see this? Any other counties? Okay, I'm going to start off with 150 grievances. Can you see that? Can you see the 150? I guess nobody's saying no. Okay, this is our data 1. Can you guys see that here? Can you? Okay, this is our data 1. Now, 150 grievances. Oh, thanks. Let me doll this up a little bit. I can tell when everybody gets real quiet, they're trying to, it's like I'm losing them. So I'm going to go ahead and catch it back up. Okay, data, this is data 1. Now 150 grievances. Let's say we had a caseload of 1 million clients. You think 150 would be bad? Probably not. Sounds like we'd be doing pretty good, right? What if our caseload was only 200 clients and we had 150 grievances? Now that would suck. Excuse my language. That would be bad. Okay. So in this example, I'm going to say, let's say our caseload is, we have 2,000 people in the system. This gives us an idea here. We have 150 people in with the grievances, and we have 200 in the caseload. This would be data 2. Okay? So, and I did pass out calculators. I don't know if you have them or not, but that's okay. I'll do the math for you. If we take 150 divided by 2,000, we're going to come up with 0.075. It's the same as 7 1/2%. What this tells us is 7.5% of the clients file grievances in the system. And 7.5%, what that means is 7 adults and 1 child, 7.5. Out of every 100 filed a grievance. You know, the kids are going to file them too, right? Okay. I'm going to flip this page a second. Now, when you get an equation like this, 150 over 2,000, that's how many people's in the system. This is what we call a performance measurement. Haven't done anything with it yet. Somebody says, what's your performance measurement look like? You'd have to draw it like this. Well, this is what it looks like. And then that will kind of tell them what you're doing. Once you execute your performance measurement, you're going to end up what we call an indicator. Once I execute it, once I take the 150, divide by the 2,000, I'm going to end up with just look it up, just say 7 1/2%. Okay? This is our indicator. This report indicates 7 1/2% of the clients weren't happy. Does that make sense? That's why they call it an indicator. I'll say it again. This report indicates 7.5% of the clients weren't happy. So we had 2 sources of data. We needed the second source to make it relative. Like I said, it could have been 1 million clients. If it was 1 million clients, it would be good, because 200 clients would be very, very, very bad. So this helps us keep everything relative. And it's raw form, it's performance measurement, and once you do that, you execute that performance measurement, you get your indicator. This is called an indicator. Does that make more sense now than when I started off? I knew it would. I just need to backtrack there and catch up. And we're going to go over this a little bit more. Okay, so does everybody at the other locations understand what we mean by indicators so far?
Can I ask you a question,
Yes.
Kathy? Just generally, when you go to QIC meetings, I mean, do most counties at least generate reports that have all these elements, or are they sometimes really slipshod and they don't even have?
There you go. I like the second part.
Okay.
Sometimes
great.
they really slipshod and...
They just have the data, like the first data, but they don't have it.
Right.
They never make it relative to anything.
Right.
So.
Not always, but many
Generally.
times. And I'm going to get to that in a minute. I'm going to give you a sample report in the year 2005 from my county. That was a verbal report on a state-required mandated report that should have been in writing. And we only had, well, you'll see what's going on. We only had 1 indicator when there should be 2. Now, so far we have 1 indicator, 7.5%. Okay? Many, not many, it seems like almost every single QIC meeting I've been to only have 1 indicator. But it's not about quality assurance. There are 2 different things. Quality assurance is bean counting. You're doing something. You're doing what the plan asks you to. You're signing in your name when you come in the door, all that kind of stuff. That's quality assurance. Quality improvement is a lot different. Did we improve since the last report? Right? In other words, I see this report in front of me today, but did you improve over the last report we got? And they're just like, why would you ask that? Well, I don't know. That's quality improvement. Right? Let's say it's not a quality assurance committee, it's a quality improvement committee. So the key word here is improvement. So now we're going to go, and I'm just going to slip through another one. We talked about indicators. Okay? Now the first, let's just say, let's say that was last year's report was 7.5%. That was last year's report. So we got 7.5%. This is our indicator. Let's say this is for year 2004. Okay. Now we say, let's see what's on this next page. I am. That's where I'm going with this right now. Okay, now let's say that was last year's report, 7.5%. Now let's say they do this year's report, and they say, guess what? They passed out the report, slipshot. It says, okay, this year we only had 125 grievances. Well, last year it was 150. This year it's 125. Sound like it improved?
Yeah.
It does, right? Let me show you an little trick. I told you I was going to make this interesting. Before I got the Hardy Boys mystery, now we got the glass. Okay? Now, looking at the glass, would you say the distance from here to here is the greater distance? Or the rim around the glass is the greater distance? Looking at it, what would you think? Straight up and down is the greatest distance, right? Okay, so I got a buck here to help us figure out if there's where we are on that. The dollar is almost as tall as the glass, right? But will the dollar get around the glass? Yeah, fooled you, didn't it? Just like these reports that come out in QIC. This 125 grievances is exactly the situation we have here in my hand. Let me tell you why. There's budget cuts and all kinds of stuff going on last year's layoffs, and they only had 1,000 people in their system. Of course, you didn't know that because they didn't tell you that. So when you do the performance measurement, you come up with 12.5%. So it went up. So what really looked great actually went the other way. That's why it's important to have two sources of data. And you'll get a kick out of going to these QIC meetings. It's very simple. It's just I have a concern that two sources of data. How many people are, the grievances? How many people are in the system? Do your simple math. It's very simple, and it works for everything. And then ask them the greatest question of all. Where's your last report? Ooh, they don't really sound well. You'll see. You'll have fun with this yourself. Okay, so this is what we talked about indicators. Have you ever seen, I like to show this one off, the sick bay in Star Trek, you see those little indicators bobbing down? Well, that's what it is. That's what we're doing. We're looking for indicators. We need something to compare and see if our county is healthy. What we got next? I don't even know what's next. Let's see. Okay, now we're going to shift gears a little bit. We talked about some tools to get you started in QIC. We talked about root cause analysis, and we talked about reports. So when we go to our first meeting, we have an idea of what we can look for. Oh, by the way, the manual goes way in more depth. Okay. Why do we need a quality improvement committee? Anybody have any idea why we need one? I'll tell you. Why do we need one? You
so it doesn't get worse.
So it doesn't get worse. Okay.
You're a pessimist.
Yeah, I love that. So it doesn't get worse.
It was worse.
Or how about so it gets better?
Yeah, right.
Right. It all depends on half full, half empty. Medicaid. All states in the U.S. have some sort of a Medicaid. And usually states can deliver services usually for the lower poverty level people their own way. And there's something called a Freedom of Choice Act, in which they could deliver services their way as long as one thing, it doesn't affect the consumer negatively, right? So let's say Medicaid in California is called Medi-Cal. It's called California style. You know, Californians, the surfers, we're gonna have everything their way. You know, so now we got Medi-Cal, which is really Medicaid California style. There's one thing about Medi-Cal though, it's a monopoly. What does that mean? It means that if you have Medi-Cal and you want to go get a provider, you're going to have to go through the county. And not only that, let's say you go to a private provider. The county approves the private provider. You've got to go through the county, through the back door, one way or the other, you have to go through. And the county approves who the providers are. So the feds said, well, if you guys want to have the monopoly, you know, we need some assurances. Well, I said, okay, well, we'll give you some assurances. So they came up with California, or the State Quality Improvement Council, which used to be called the State Quality Improvement Committee. If you ever see the word committee out there, that's the way it started out, and then later on they changed it to council. And that would be the state, okay? And they do the special studies and some of the deeper and more intricate things. Each county has a Quality Improvement Committee. Now, let me talk about the counties for a second. There are 58 counties in the state of California. Last I heard, it was 55 of them had their own mental health plans, but that's actually went up since last year. Now I hear it's 56 had their own mental health plan. A mental health plan is just a way, it's just a plan that the county shows to the state, to the feds, on how they're going to conduct business. So that's why we have a state Quality Improvement Council and Committee to make sure, this is the phrase, to make sure it doesn't, their services do not affect the patients negatively. You want to have a monopoly? Show us you can do it as good or better. California thinks if they pull their resources together, they can do it cheaper and save themselves money, so that's where they do it. This is kind of cool. This is called the Crossing the Quality Chasm. There's an actual book titled this. You guys are aware of this?
A couple of us are.
A couple of you are. It's written by the state, or actually it's written by the Institute of Medicine, and they found out there was 6 aims. And what the state of California is trying to do at this time, they may have already done it, is try to incorporate somehow these 6 aims into the language of the quality strategy. And as you know, when somebody has an idea and then you try and incorporate it into law, it's easier said than done because, it raises a lot of red herrings as you try to make that incorporation.
For the folks in the other offices, it's on page 7.
Yeah, I'm sorry. Good idea. Yeah, page 7. But actually, once I started reading these 6 aims, I became really interested. And I ordered the book off Amazon. So this is it, Crossing the Quality Chasm, so it does exist, and it's pretty interesting. It's pretty neat the way they do that. So they're working on that now, and what I liked the best was the first one, safety. To me, that just sums it all up, avoiding injuries to patients from the care that's intended to help them.
Yeah.
I mean, if people were helped and not hurt, you guys would all be out of a job. They wouldn't be calling you up. They'd be, oh, I'm happy. What do you need me for? But let's face it, it ain't happening, and that's why we're all here. Okay, now we're going to go to page 8. Is everybody on page 8? Now your page 8 looks like this page 8, I promise you. I would like to do one more round of, actually I'm just going to go ahead and read this one. This will be it. I'm just going to go the first 2 paragraphs. Sometimes it's written better than I can say it. I made sure it was. Okay, why would a quality improvement committee procedure manual be helpful? Many people do not have the slightest idea what a quality improvement committee does. It may be that visitors and new members come to the monthly meetings, yet remain in a fog as to exactly how they can contribute to the process. I've seen that a lot. It all seems so very complex, and I've seen your guys' faces a while ago. So they sit in the meetings and try and wing it, hoping for more clues from meeting to meeting. For this reason, many become discouraged or drop out. And who can blame them? Who would want to play a board game that is missing the instructions? One gets the feeling the rules and goals change depending on who is running the game. For this reason, the California Network of Mental Health Clients voted to create the QIC manual as a step-by-step guide for clients to participate knowledgeably and effectively on the quality improvement committees. This manual will explain how performance improvement begins. It will explain the state to county QIC policy and guidelines. It will help diminish the vagueness associated with the function of QIC. And it will explain and simplify complicated and confusing data. It will help explain the importance of collecting data that is accurate, appropriate, and which reflects the entire process. And that's what we were talking about. Make sure you get that data 1, data 2, develop your indicator. And get the indicator from last report. 4 things, really. It will help identify resources available for brainstorming and problem solving. It can serve as a handbook and be used universally as a teaching aid. And speaking of that, go ahead and feel free to write in this book as much as you want, make all the notes you want. As we know, okay, we covered that QIC is for Quality Improvement Committee, and each county has one that has an MHP. MHP is your mental health plan. Okay, let's see what's next. It's a big mystery to me, too. Okay, here we go. You know, when I first started this whole process, they said the word stakeholders one time. I go, what is that? Somebody holding a stake and, you know, the vampire's name? I don't know what it is. Stakeholders. Well, in QIC, there's a regulation, WNI code number 1810-440. And it talks and tells us what stakeholders are. Stakeholders are consumers. Well, I put them at the top because I think they're the most relevant. Relatives, spouses, providers, legal representatives, other persons similarly involved, and a licensed mental health professional. You see that where it says a licensed mental health professional? So it sounds like we've got a lot of people on the outside that wants to be involved, and we're really interested in at least having one licensed mental health professional. Well, I can't tell you, when I first got the minutes from our particular county, it had, I'm going to show you. And for those of you over there, I'll tell you what it says.
What page is that, Kathy?
This is something that's a teaching aid. This particular page, all these are email addresses. They're all county email addresses. There's one that says Earthlink. That's mine. Okay? First thing I did is said, who's representing this QIC committee? I'd like to know. Well, after I asked them who's representing the committee, they kicked everybody off. And then they had everybody reply again. So everybody was represented fairly. And they said, thank you for bringing that to our attention. Okay, now we know who the stakeholders are. Next thing is, what kind of responsibilities can they have, or duties? And I like to use the word clout. What kind of a clout do they have? Because that's what they want to get something done. I've heard some people say stakeholder clout is making recommendations. Oh no, they don't make recommendations. They shall have an active involvement in planning, design, here's the word I like, execution. That's not making a recommendation. You execute something, you're part of it. And that is also part of 1810-440, if you look up the code. Now, we're going to go into the next part. This planning, design, execution, they have this cloud over what they call a QI program and also a QI plan. The QI plan tells us what the QI program does. So they're both the same but different. Kind of like a marriage, you know. You're both separate but one. Okay, now I'm going to go to page 10. This is page 10 simplified. We're going to start off with, let's see what page 10 looks like myself. Every single mental health plan must have a QIC committee, or sometimes they call them commissions, but it's some sort of agency or committee. Every committee needs to have a QI work plan. This is a blueprint. It outlines what they're going to do and how they're going to do it, who's got the responsibility. Now I would say this is what you should ask for. We're going to go into this a little bit more later, but if you go to your first QIC meeting, you might want to call in advance. Say, I would like your current quality, QI by the way is for quality improvement, I'd like your current quality improvement work plan. The next thing I'd like is your last quality improvement performance evaluation. Every year they have to send to the state how they did. Hope they don't hang up on you. The next thing is minutes. Ask for like the last 3 months of minutes so you can kind of get an idea of what's been going on. And the very last thing is ask for several reports to get an idea, how they're doing the reporting. Yeah, that would be the good thing to ask for. Your QI plan, the last QI performance report, minutes, and reports. Page 11. Your 11 should basically look like this one, except mine's black and white. MHP, you're going to see that throughout the manual, stands for Mental Health Plan. QIC is Quality Improvement Committee. Can't say that enough, because some people, I got to the end of the training, I go, no, what's QIC mean again? QI program is the Quality Improvement Program, and QI Work Plan is the Quality Improvement Work Plan. Now I get kind of a flow chart, so you can see how the responsibility works. The mental health director, the clinical staff, and stakeholders, which is what we discuss as family members and the consumers, they're all part of the QIC committee. Okay. From there, it branches out in 2 directions to simplify. It's really the same thing, but to simplify, I put them separate. Quality Improvement Program is what the QIC plan designs and executes, and it also plans, designs, and executes the Quality Improvement Work Plan. Okay? And then that is going to dribble on down to a written evaluation once a year. How well did we do? Okay? This is our plan. The state wants to know, okay, this is your plan, but did you guys do what you needed to do? I was going to say that once you get this evaluation plan, in fact, you might want to ask for the county's last 2 quality improvement plans, because sometimes their evaluation report, what they did, and what they set out to do, they're very different in some areas, and it's just very interesting to have a look at that. Okay, this is number page 13, reference page 13. Looks like this. This is the Quality Improvement Work Plan for Riverside County. Inside of this work plan, it also has an evaluation report. And that's what we have here. This is for the Quality Improvement Program. And this is a blueprint. This is what, it'll give you an idea when you come to the meeting, what is it we're going to accomplish? What is it we hope to do? This will give you that information. Okay, now, by law, they're mandated. It includes an annual evaluation on the effectiveness of this plan. It also monitors 6 state-mandated items. We're going to talk about that in a minute, just very briefly. Also, 2 performance improvement projects. Those are called PIPs. Also monitoring previously identified issues. You might consider, I had a concern there was 150 grievances and there's no other data or indicator. That would be monitoring previously identified issues. Other areas identified by QIC and staff. So if you guys might want to bring something up. QIC tools to include, you can create special surveys. You can initiate special studies to get your information. Analyze data, and you name it. Okay, we're going to flick it over to page 14. This should look like your 14. These are the 6 items mandated by the state, which is has to do probably with the feds, what they're looking for also. The Quality Improvement Committee monitors, plans, designs, and executes the following. The service delivery capacity of the mental health plan. That would be one of them they have to do. They have to actually give a report on how well they did that. Accessibility to services. Beneficiary satisfaction. The mental health plan's service delivery system. Continuity and coordination of care with physical health. That means your caseworker, they coordinate your mental health with your physical health. And provider appeals. Provider appeals would be if a provider's getting turned down for payment, they're going, hey, no, wait, we met all the criteria and we would like to get an appeal. So QIC looks at that. If there's getting a lot of provider appeals, they may say, what's going on? The next thing they do is follow up. That would be monitoring of previously identified issues, including tracking issues over time. That's Elaine's 150 grievances she's about. And other areas of concern concerning QIC. Conducts monitoring activities included but not limited to review of beneficiary complaints and grievances and fair hearings, provider appeals, and clinical records review. So you pretty much get your hands in anything you want. And PIPs, 2 performance improvement projects, 1 clinical, 1 non-clinical. And all this comes down to one thing, an annual evaluation of the overall effectiveness. This is going to be in a report at the end of the year. So all this stuff they've been doing all year gets into a report. Okay, page 27, hop around. Page 27. Now, I think Pima said something a while ago about a report, asking if it's possible we get these kind of reports. Actually, we did get a report that was didn't have enough information. What this particular report was, somebody came in, they did a verbal report, it was one of the staffers, and she said the Central Access Team. They were trying to find out if the Central Access Team was doing what they're supposed to be doing. There's a certain amount of questions they're supposed to ask, and they're supposed to be answered. Well, it's up to the person how they answer them, but at least there's a certain formulary or protocol on the questions that need to be asked. So they get what they call sticker shoppers. They have people from the county that calls them up and finds out how well they did. Well, this particular verbal report, which this is a state mandated item, should have been a written report. Data 1 said, or they didn't even put data 1, data 2. She goes, we made 17 calls, 3 calls were rejected, and that's it. And they moved on to something else. I'm like, well, wait a minute, let's go back up here. So now, how many people did you call? She said, 17. And I said, how many calls were rejected? She said 3. And then they moved on. Well, I took this home and I thought, no, what does this mean? And so then I did the data 1 was the 3 calls rejected. The 17 calls were made was data 2. I did the math. And you know what I found out? That I think it was like 17 or 18 bets. If you do the math, it's like 17 or 18% rejection rate. It doesn't sound so bad when you say 3 out of 17. But gosh, could you imagine if 18% of your whatever you ordered from the store was getting rejected? You'd probably go to another store, right? So the point was, and oh, by the way, I asked the QIC chair about this, and she said, well, I asked for the written report. She said, the point was, we made 17 calls, and she reported that 14 were logged by the program correctly, and 3 were not. That was a report, and what the state wants to know. That's why we need to have people on these committees to be looking and understanding these things, because that was, like you said, slipshot through. Or I like slingshot. So, missing performance improvement measurement. Okay, now we found out we had an indicator. I don't recall. I think it was. Yeah, could you use your calculator right there real quick and do 3 divided by 17? It was 18%, so I did recall right? Oh gosh, you guys are on top. 18%. Okay, so now So 18% is what? What do we call that? An indicator. That's the indicator for this year. You know what I'd like to know? What was the indicator for last year?
Yeah.
You know, was it 20%? Well, then we improved. So 18%, even though it sounds bad, it's an improvement. That's good. If it was 8% and then it shot up to 18%, whoa, what happened? And then once you do that, once it gets to that point, you might decide, if it goes up, you might think, hey, let's have a subcommittee, a QIC subcommittee. Now, it's not so formal. I mean, people get around and brainstorm. This is after looking, I went actually on the internet and I looked for a lot of hospitals and how they do corrective action, and I sort of put together the best of what I was able to find. And this would be a good protocol, I feel, for a subcommittee. First, you'd review the report, and then you review the indicators, right? So far, you're with me on that. We looked at the indicators. Maybe they look high, low. And then we review the source data, or where you get your data, how you're getting it. And then we're going to state our concern. Concern might be, well, we'll talk about that in a minute. Once you state the concern, then the question's up for grabs. Do we need a subcommittee based on the concern stated? If no, continue to monitor. If we need a subcommittee, then we've got to define the project. We say, phase one would be, what do we hope to accomplish? Why are we going to have a subcommittee? The next question is collecting data. How are we going to get the data to satisfy our concerns? We could do surveys. We could, put out a consumer survey, a special one. We can collect some, maybe some databases through clinical charts or special studies. And once we've done that, then we've got to develop our indicators from the data. We've collected all this data, but it's got to mean something. So then we have to decide how we're going to use data 1 and data 2 to come up with our indicators. And all this is done through subcommittee, through brainstorming, deliberation. You guys like that with deliberation, huh? Okay, then proceed. At this point, they're going to look at the information. Does the indicators we have look outlandish? If it's no, we continue to monitor. If yes, then it's going to go in a circular thing. It's going to, first of all, we're going to develop and activate the corrective action, what we feel might need to be done, which might be, maybe there's excessive restraints. We're going to think corrective action would be answer restraining. And maybe we want to give them multiple choice questions. And they could answer the question about restraints, multiple choice, and we'll stick it in their file. This way, when something goes wrong on a job, they say, well, nobody told me about that. Well, let me go look at your file. You knew the answer to this question. Look, see, that would be some corrective action. Number 2, collect new data, remeasure, evaluate results. Did the in-service training, was it effective? If it wasn't, we can modify the training. If it was effective, then we could say, we're going to modify our policies and procedures. And then we're going to monitor to hold the gains. We don't want to backslide. Now, I'm going to give you an example, if I can remember it. Okay, this would be page, I think it's page 29. Is that right? This is phase 2, by the way. We're going to go to evaluate results, number 2. So we're going to collect new data. Are we getting less restraints? Yeah. Okay, so that's good. So then we draw conclusions about improvements. Well, we're getting less restraints. It's significant. It's not down a little bit. It's significant. So we decide that's good. So then we're going to go to the next one, which means we're going to modify policy and procedure. We're going to put it into our quality improvement control manual. And they're also going to communicate these changes to the affected areas. Then once that's all done, we're going to monitor the whole gains. Okay? So that would be, I think, a good layout for quality improvement. And notice this wasn't looking so much as a single person as policies and procedures. And usually you can get a lot more done if you're not trying to lay the blame at somebody's feet, because white people will really run away from that. But if you can affect policies and procedures, you're probably going to get a lot further, and you're probably going to get a lot more done. Okay, page 30. Checking the minutes. The minutes are a summary of what happened in the last meeting. Do they appear to be objective? meaning do they portray what happened in the meeting? Sometimes a QIC meeting will sound like everything's done great, and some of the questions that you might say, I had a question about those 150 grievances. Maybe it'll be portrayed in the minutes in such a way that it almost sounds positive that somebody asked rather than there was actually a concern. And when you look at these minutes, if there's something in there that's like you raise a concern, ask for the minutes to be changed to reflect the concern that you have. A lot of times, clients, consumers are afraid, and they will just nod. And in the back of their mind, you're thinking, you know, it's not right. This isn't what I really said. It's not what I meant. Speak up. Say what you said and what you meant. Are there any important subjects missing? Let's say somebody brought up something about benzodiazepines. It's a certain kind of medication. Maybe somebody would say, you know, I'm concerned maybe we're using excessive benzodiazepines in our particular county. I've seen some other counties are trying to get off of it. It's a very addictive drug. And maybe that's not in the minutes. Well, bring it up. Say, you know, I brought up this thing about benzodiazepines. I think it should be in the minutes. Look for a balance. Does it look overly positive? Like we're doing a great job, we're awesome? Or is it objective and it says, well, you know, there's some other places that we're having problems and we need to work on. That's important too. And the other thing is, a lot of times things will get set aside for action items. Maybe Elaine might say, you said there were 150 grievances, but can you tell me how many people were actually in the system? We don't know that. We'll get back to you. Well, make sure the next meeting, they do get back to you. Make a note of it. Getting on the agenda. You could call the QIC chair or whoever that person is and say, hey, look, I have this concern. I'd like to get it on the agenda. You could send them an email for the particular concern you have, CC a copy to yourself so you have a record of it. Or you could also send them something in the mail. Point is, get it on the agenda. If it's a concern to you, take some steps to get it on the agenda and talk about it. This isn't just somebody making up an agenda, everybody following along with it. Bring up your concerns. Be a part of it. Okay, we're just going to go a lot faster now, I can tell. Page 31. But you guys know the answer to this one. What's the difference between a grievance and an action? The state redid its terminology, I think it was a year or two ago, the difference between a grievance and an action. It used to be complaints. I think of it like this way. Grievance has to do if you're upset and mad because somebody was rude to you. Action has to do with money. Is it actionable? You know? Usually people don't care if something's actionable unless there's money involved. So a grievance, these are some explanations. Reception staff was laughing at me. Come on, you got a grievance. Staff keeps hanging up every time I call. That's a grievance. A staffer called me a sicko. Well, to me, that's a complaint. Now, I really like to see it called complaints. Grievances almost kind of minimizes it to me, you know. And then actions. My appointments were cut back. You know, I need to see my therapist every week, not every month. I'm gonna end up not joining, the hospital. Keep doing that to me. So that would be an action because they're cutting back. It has to do with money, right? Cut back money. Medication refusal. You say you need Restorol to get to sleep at night. They said, no, we're not going to give you Restorol. And they won't give you anything anymore. Well, there's an action there, too, because it's interfering with your ability to function within a community. They cut off your services. We're not going to see you anymore. Well, there's a good savings of money. That would be actionable. Services refused. My son is mentally ill, and I can't get services or help through the mental health plan. Well, that would be actionable. I think we covered that. It has to do with money. Usually action has to do with money issues. And grievances is just somebody's upset about something. Okay, now page 32. My 32 should look like your 32. We got a flow chart how this works. Grievance, you got one chance. In other words, if you fill out the grievance form and you send it to the county, somebody is going to look at it and say, well, you got a point or you don't. And that's the end of it. There is no second person to look at it. There is no other agency that will look at this. That's it. It's final. Action, you get 3 chances. The level 1 would be the initial decision. No, you can't have your services come back, we're not going to do it. So then it goes to their supervisor, somebody that wasn't involved with the initial decision. And they might look at it and say, well, I agree with the first one. You're still not going to get your services. Well, from there you can take it to an administrative judge, which is a state fair hearing. And that particular person, that judge might reverse it and say, yeah, we're going to give you the services. So you actually get 3 chances on an action, 1 chance on agreement. And I really think this is the reason why we need a quality improvement committee. We need people on the committees to watch out for these things, because maybe there might be a lot of grievances that year. And somebody in that committee could say, because remember, they only get 1 chance. 1 chance denied, that's it. You know, yeah, somebody called you sicko and there's no proof, there's no evidence, and that's too bad. So if we're getting somebody on the committee that says, you know what, I would like to, remember we talked about subcommittee categorizing those complaints? Somebody's going to look at that and say, you know what, it looks like after we did our subcommittee, somebody's going to want to complain at the one particular facility. So it looks like maybe there's one person who has a habit of calling somebody a sicko, you know? You might find that out. Why is it this one particular person, this one particular place? So even though you get 1 chance, and somebody's doing the watchdog for you in the QIC subcommittee, it's going to help out everybody. Okay, so that's it for that. Page number 35, which should be 35A, B, and C. These are the 3 charts. You should have them in your, it's the 3 charts we have. Yeah, it's actually right after page 35, which would be 36. I just call it 35A, B, and C. If you want, this is actually on the state website. I'm not going to discuss this too much. I'm just going to let you know it exists, and it's in your manual. This will tell you the flow for the grievances. This clearly shows you only got 1 shot. Appeals. Now, also a grievance, by the way, if they don't do it within the 60 days, then it could become an action. See, they can graduate to an action. But basically, it's a 30-day, it's a 1-shot deal. It just shows you the flow chart for appeals. I think a lot of times if people want to make an appeal, they want to know what kind of process they have to follow, so this is the flow chart will help you. And expedited appeals. Let's say you can't wait a month for somebody to find out if you're getting denied certain medication. You know, I'm going to the hospital in 4 days. I don't have a month. So then you got this route, the expedited appeals. Performance improvement projects. This, you can have a 2-hour session on this, easily. You know, and we're not going to go there. I'm just going to let you know that it exists and go over an overview of what performance improvement projects are. The purpose of, they call them PIPs, that's the lingo they use. The purpose of a PIP is to assess and improve processes and thereby improve outcomes of care. And what sets a PIP apart from the regular report is that a PIP must be designed and conducted in a methodically sound manner. In other words, they're going to look not only at the data you get, they want to know the formulary of how you got that data. And then they're going to go back and see, was it trained people that took the data? Or was it somebody that was just, you know, temporary people took data? I mean, they get really sticky on the PIPs. They want to know, you know, it's like discovery. Where did it come from? And data could be based on, you know, the enrollee characteristics, standardized measures, diagnosis, and outcome information, just a whole host of things. And the QIC needs to do 2 of these every year. One's got to be clinical, and the other's got to be non-clinical. And each PIP begins with a study question. This is what kind of makes it simple. Remember we talked about reports, I have a concern. Well, a study question could be something like, will the training inpatient hospital staff significantly reduce the number of times patients are being put into restraints? That would be a study question. Well, with the PIP, you have to measure 2 points of time. Before you did the PIP and the training, and then after. And then you compare them, and you find out, was there a significant improvement? Usually if there's been a significant improvement, then you can tell if the PIP has been successful. If there hasn't been a significant improvement, then I don't know if it's really that, successful or not. So here, to proceed with our PIP, we must measure performance at 2 periods of time to find out if improvement has occurred. First period of time, we develop an indicator to compare the current number of times patients are being restrained. Okay, I don't know, we have 1,000 admits, say a month, and 50 patients are getting restrained. Okay, our indicator's 5%. The second period of time for a PIP, we compare the indicator from our first period of time with our new indicators after inpatient training. Has there been a reduction in use of restraints? Well, we did a comparison. We found out it's not 5% anymore. It's like 1.2%. So, that's pretty significant. I would say it's pretty safe to say that there has been some improvement. And PIP.
I wanted to ask a
yes.
question. Would that verbal meeting of the 17 telephone calls have been just about minutes for about one of these projects where it's supposed to have so many parts and it have 2 different times? Because it doesn't sound as though they stated what questions they were asking once they got
No, that wasn't a PIP. That report wasn't a PIP. PIPs are
it's mostly in writing?
PIPs are, it's gonna be like a clinical chart. There's just gonna be a stack of stuff. You've got regular reports that come through the committee. Those are just the 6 mandated items by the state. Maybe something you brought up. Maybe you have an agenda. You want to have a special report. PIPs are something that's completely different. These are usually study questions that either QIC will come up with a study question, or maybe even the state. The state might come up with a study question and say, we want you guys to go through it and figure out the answer to the study question. So there's only 2 PIPs, but you can have as many as 100 reports. There's only 2 PIPs. PIPs are assessed to determine the likelihood improvement is real improvement. One way to make this assessment is to calculate the degree that intervention is statistically significant.
Kathy, can I ask you a question?
Yes, please.
Because I'm actually a little confused. I mean, when just looking closer at that chart about beginning with a study question. My understanding is, and I always thought that the performance improvement project, that they actually, I thought of it more as like a little, almost like a pilot program, but it's not necessarily like that. It can just be wider spread. Measuring the performance in a particular area, or is it?
It could be a pilot program. It could turn into something that proceeds on to a full-blown process later on. Right now, Medicaid, the way the services are funded through the feds, right, they're requiring California to start doing some improvement. And then what they want to do is they said every county gets to pick 2 improvement projects. And those projects might start out something simple. They're encouraging people to pick out simple study questions, just something very simple, that they have the actual resources to implement. I mean, if you ask these hard study questions, you may have to dig up discovery all over the place, and they just don't want to invest in that. It could turn into something really good and proceed further, or it could just be satisfying the county requirement to have study questions. PIPs are brand new. This is something brand new, and there's many counties that are just saying one to learn on, one to work on. They're almost saying it's that kind of situation, and they're encouraging people not to make the PIP questions too hard, right? Because they want them able to follow through and get through it.
So like Riverside's last year, what?
We don't have one last year because we're still working. All you've heard of the EQRO, the External Review Quality Organization. And it's an external contractor that was hired or contracted through the state to go through and check these PIPs, see if they're right. And they also check things like penetration rate, how many people under 18 years old and how many people over 18 years old are penetration rates within the system. I think that kind of answers the question, doesn't it? And this is just, like I say, it's brand new, and a lot of people are just trying to survive and get through the PIPs. Probably after everybody gets a little more training and the results are in, I would assume that after the EQRO looks at it, and the state and the feds are probably going to come back and say, well, looks like you guys are okay in this area. We'd like to see some other study questions in this area. And like I said, the county can pick a study question at this time. But the state has the option of telling them what their study question is going to be. And it may be that way. I mean, if people are picking out stuff that's ridiculously simple just to skate by and, just get their Medi-Cal dollars, and it's feds might notice that and say, well, we're going to up the bar a little bit.
I have another question.
Yes.
There's two regions that are not counties, the Tri-City area near Pomona and Berkeley. Tri-City went bankrupt. Would they be doing this as well? Because you were counting counties, and they involve 3 counties, small area.
Right. To my understanding, only the mental health plans. Now, there are some counties that will have a contract with another county, and they'll take on the responsibility of their mental health plan. So I'm not sure. I mean, and then there's also special arrangements that some of these counties have through other interagency agreements and how they set it up. But I don't know so much about that as I do the 56 counties that do have mental health plans. The ones who don't, they're probably responsible in some way through another oversight agency. Maybe they have a contract with another neighboring county. That could be possible. That would be something to look into.
Thank you.
Any more questions? We're going to go past performance improvement projects. And page 39.
Yeah.
At the last moment, I decided to change this to looking ahead, try to be something more positive, okay? Now, I couldn't help it. I just had to add this page in the manual. I would like people to ask themselves, when they go to a QIC committee and you sit on it for a while, ask yourself this question. Is the committee passive? Meaning, as the reports get through and circulate, and they just, yeah. Let's move on. Yeah. That's kind of passive to me, okay? How about reactive? When something bad happens, well, let's get our ducks in a row and look at it. So usually the passive thing goes on until something happens. Well, the passive people won't even do it when it happens, see? But at least the reactive people will at least take some action after it happens while they're passive in the meantime. How about active? Active would be looking ahead, anticipating where the problems might be before they actually happen. We might anticipate the type of data we need. We can anticipate verifying data sources. Are they good? Are they valid? We could be doing something in the meantime instead of sitting there nodding our heads. We could be verifying the data collection methods. Is a bunch of temporary people coming in doing this, or is this somebody who's been trained? Does the report have the data required and the indicators? That would be looking ahead. Does the report even exist? You know what, I was going to my QIC committee for a long time, and one day I said, you know what, I don't see anything about inpatient reports for restraints. We don't have that. Well, why don't you have that? So these are the kind of things that you could look for and ask for. And just because it don't exist, it's not, or I should say, just because you don't see it, or because it's not there, doesn't mean you can't ask for it. Okay, that was page 39. I hope I said that in the beginning. Let's go to 49. This is the one I like, especially, with the backdrop of all these logbooks here. 49 is actually 1810-440. It talks about the cloud QIC members have in the Quality Improvement Committee. And you can see here, doesn't say one single word about recommendation that I can find. It talks about planning, design, and execution. Okay, we're not going to minimize people's ability to get something done in QIC. If somebody says, well, that's not really what your job is or what you can do, refer to 1810-440, number A, 1, or A, number 2. Okay? planning, design, and execution, and you're part of that. Okay, that's number 49. Now we're really going to go fast. Okay, now this one on your page number 40 to 41, it's going to talk about Medi-Cal, the history and waivers. That would be good to read. It's going to discuss about how Medi-Cal came into being, why they call it Medi-Cal. It's going to talk about how the services increased from, it started out just a state inpatient, and then after a while it got to be more county responsibility, where the county is responsible now for the inpatient, the local mental health patients. And also for case management and other kind of rehabilitative services. It's got a history and all that. And it also talks about the waivers and why they're important. So California can do it, Medi-Cal, there's that. Okay, let's go to knowledge and depth, page 43. This would be a good section if you want to talk a little bit more about some of the, like PIPs and depth, what they do and why we have them. Page number 47. It talks about the uses of words and phrases, some of the ones that are common throughout the manual. Page 50. I wish I had a buffer every time I said Page 50. It talks about acronyms. What's QIC mean? So I thought that would be helpful to have that in there. Page 52. Suggestions for data sources. This is actually some of the data sources that the State Quality Improvement Council uses, and they exist, and it helps them facilitate some of their studies. So I thought I'd list them here for local communities as well. Page 57, references. Give you an idea where some of the references for this stuff comes from. This is the, I don't know if you can see this or not. This is the mental health. I got this off the State Department of Mental Health website. It's really a cool book. They got the 2005 edition out now. And it's got the laws and regulations. And not only for Title IX, it's got Title 22, some penal codes in there, health and safety code. It's rich with information. It's very thick. And what I did is I just put tabs, 5150, 5250, and all kinds of things so I get there fast. Also, this is also cleaned off this big quality strategy, and you can see it's just a ton of information here. You can get this off the internet too. I don't know, it's hundreds and hundreds of pages. And like I said, this manual can be beefed up, but I don't think it needs to be. If we make it more complicated, people aren't going to use it. But I'm just letting you know this is where some of the information was gleaned from. And also, registrar rules and regulations, and also a lot from the State Department of memo notes, and just, I don't know, I've been through this material like 3 or 4 times, just looking for things. Because I want to make sure you had everything you needed. Now, that said, we're going to our last page, and we still got 20 minutes left. Anybody guess what it's going to say? Free trip to Hawaii. Let's pull out the answer. Yeah, nap time. Here it is. This is the Far South Project for California Network Mental Health Clients. Congratulations! You've finished the workshop. Thanks to Pamela and Sally Zinman, our executive director, and Pamela helped us get this together, and that was wonderful just to get this video conferencing, and also to the 4 contact people that helped us get this together. We really appreciate it. And any questions? When's the pizza coming?
Yeah, I've been trying to engage a local QI in Santa Clara County.
Yes.
And I feel like I'm in this phase where I heard them say we're in an informal, formal, informal process, and it's not in writing. And then, does that trigger some back office operation, like to do audits or to figure out if something's actually happening the way it's supposed to happen and is invisible to us?
Well, actually, that's a pretty good question. Every mental health plan is mandated by law to have some sort of oversight. That would be a quality improvement committee or a quality improvement commission, quality improvement, whatever they want to call it. every single meeting, I think it's mandated to like 10 meetings a year, and each meeting has to have minutes. So there's got to be some sort of evidence this meeting existed. The EQRO, which is now APS Healthcare, they're supposed to come in and audit these minutes and see what's going on and make sure their meetings are happening. So as far as it being in a public arena, I'd like to see some legislation.
No, I meant like within the county, is there an invisible process to audit their subcontractors that they're meeting up the expectations that they're contracted for?
Did you say invisible?
Personality config, huh?
Is there an
invisible? Complain about someone, and then they have back office operations that's auditing this because you're the client. They're keeping you out of loop because that's client neutral, you know. So they do that informal, formal. Well, they hear what you're saying. You write nothing down, and they're acting on it.
Well,
they got their utilization management.
In QIC, everything's above board. When you ask a question, it should be answered in the following the meeting, and that's why we follow up on our action items. So you have to phrase a question. I have a concern that, and once you phrase your question, you look for your data. If the data isn't there, you ask for the data, and that data should be provided to you in some future QIC meeting. If it's not, then you follow up on that and ask for it. And that's pretty much the way QIC does it. We just need people at the table that are actually following up on these items, and that's what the training's for, is to educate people so they can actually get on the ball, get in these committees, and follow up on these items.
Yeah, I was talking about my county's QI department, not the QIC. You know, like when you write the complaint form or grievance or call them up, you know, there seems to be something going on.
Well, that's an internal procedure with the county. Every county has their own internal procedures for their quality assurance. The QIC can look at that internal procedure if they like. They might ask, you know, we'd like to see a flow chart on how your grievances are handled throughout the department. But it would actually take somebody at the table that actually took the time to ask that question. And thanks very much. That was a good question.
I wanted to ask 2 questions. For getting started, would it be good to ask for the county report for 2004 and those 2 plans?
Right.
The projected plan and then the working plan. And then the second question is about follow-up. Does the state quality insurance council join things together for a statewide view?
Yeah, they do. I'll answer your first question. When you come to your first QIC committee, it would be good to ask for, if I was going to come to the QIC committee, I would ask for the last 2 work plans. The current work plan, which is called a quality improvement work plan, the current one, which would be 2004, or actually it's going to be 2005, 2006 now, because the counties go by fiscal year. And then I'd ask for the previous one, so you can see if there's been any changes, and if there has been changes, why has there been changes. You can kind of get an idea of how things are progressing within the county. I get both work plans for the current year and the last year. You might not even have to ask for the year. Just say I would like the current year, previous year work plan, QI work plan. Step number 2 is ask for the last performance evaluation report. In other words, how well did they do according to the plan? And it's important. It's really important to compare the evaluation report with the actual plan itself, because sometimes these reports are talking about things that's not even on the plan. And you may see, and I can give you an example of this. Let's just say we put together, and this actually happened, a inpatient, say an inpatient survey. We wanted to ask questions like, what was the most positive thing that ever happened to you inpatient? This is one they didn't like. What was the most negative thing? They don't like to use the word negative. They like to use the word like workplace improvement. Well, that kind of minimizes it when somebody's had something bad happen to them. I think it's negative. So if, let's say a QIC were to have a subcommittee and put together this survey, and they were asking these questions as objectively as possible to extract as much data that's useful. They're not trying to get positive data, we're just trying to get good data. And maybe once this subcommittee has done this and the survey has been out and put out and is actually in service, maybe the evaluation plan, it may not even be on there. you might, well, wait a minute, we had the survey, and we put this in progress, and that should be sent to the state that we actually worked on it, because that way the state will be looking for a follow-up. And how do you guys follow up on that? So a lot of things that you bring up in the committee and you initiate, make sure it's in a performance evaluation report. And your other question was?
About the state level, and I want to make a sub-question about it. Metropolitan State Hospital is under state direction, but it's in our locality, and the County of Justice, the Justice Department for USA has been following them for abuses for the last few years, and I just wondered.
I heard about that.
I wondered about bringing together all of the analysis, including something like the state hospital, to get an overview of California treatments.
Right, and the answer to your question is, as far as the State Improvement Council, it's their responsibility to identify performance measures and indicators and things like this to satisfy obligations to the feds to get Medi-Cal dollars. That's what they have to do. Now, as far as the abuses, and in fact, there was just an article yesterday, I think El Sandro, whatever, they're expanding that investigation to them. What is it? The Tascadero. Yeah, I just read that yesterday, and so it looks like, you know, there's some other things like this going on. Now, I know that the State Quality Improvement Council, what they did recently was they did, well, I guess several years ago, they did a special study on revisited, how many times people would go back to the hospital within, I can't remember, 30 days after being released or something like that. They did a special study. But as far as tracking the abuses and some of the things that are going on with these hospitals, I'm not really sure exactly how the State Quality Improvement Council fits in. I think that's why the Justice Department stepped in.
Well, I can kind of answer that, Lynn, in the sense that we really haven't seen that as something that would fall under state quality improvement because of the connection with, you know, Medi-Cal. But it is, in terms of state oversight over what another state function is doing, if there was some kind of oversight over what the State Department of Mental Health is doing. We've asked the State Mental Health Planning Council, which, are you familiar with the Mental Health?
I've heard the name, but I haven't seen
which has oversight, which is supposed to, you know, which is federally mandated also to have oversight over the Department of Mental Health and all its workings. And they've started a state hospitals oversight committee. We can talk about that. That's okay with you more after this meeting, so I want to try to focus a bit more on this, because I think the question that I have is how to get more people. First of all, I think this is fantastic, and I thank you again for making things that are really complicated and you know, more graspable, so that people can actually have a direction where to get started. But I guess the question is, you know, how to recruit more people to go to these, and I mean, you know, if you're a permanent member of the committee, can you get paid or that kind of thing? Or is there a way that we can maybe push something so that just sort of with top secret planning, we're asking that consumers who participate actually get paid for their time, you know, whereas a lot of these other people, the reason they're going to these are they're already county employees, and this is sort of part of their salary job, and so they're just going to be the same people reviewing it. But I'm wondering if maybe it's just a strategy for us to figure out a way to get the consumer input, which is really valuable, and just more incentive or like pay for transportation, come to the meetings, that kind of thing.
Well, you bring up a good point, and which brings me back to a previous point, just even getting on a committee, or even staying on a committee. Have you ever heard the term stack deck? Mm-hmm. Yeah, you know, that's when they put all the different cards in there. Well, imagine this. Let's suppose you had a particular county, and it's the county mental health director is the one that oversees, and they're accountable to him. So the QIC chair might put out applications, people fill out the applications, maybe people fill them out. There might be like, say, 15 consumers, and which I doubt, and you know, maybe 10 family members. Then they go through an interview process. They might say, let's say a particular county was a medical model, or you know, they have every county has their certain beliefs. This a particular county might say something like, tell me a little bit about why you want to be on our quality improvement committee to a family member. And she'll say, well, you know, I had a son that was mentally ill, and he beat me up and abused my household, and I'd like to see something done about, you know, people who are mentally ill. You're on our committee. Okay? Goes to the next one. why do you want to be on our committee? Well, you know, I'm looking for a job with the county, and I'm a consumer, and I think I could be a very good consumer because, you know, I've been on some organizations, but also looking for a job with the county. I think I could be a good candidate. And maybe this particular person has a pattern of not making riffs, right? Consumer, we finished the consumer category, they're not making. How'd you like to be on our committee? Okay, we got another one. Another family member. What's your position? I think anybody who's got a diagnosis of schizophrenia or anything like that, I think they should be forced to put medicated. Put an implant in them if you have to. How'd you like to be on our committee? Okay? So what happened to the people that have their QIC manual that understands this stuff and they're saying, we want to get on your committee. No, we're already full. See? So the first part of the question is getting on.
Yeah.
And then the second part, like you say, some sort of incentive, being paid or something, I think that'd be great. I would like to see the first one somehow legislated that these committees, these members aren't handpicked by the chair or the mental health director. To me, that's a huge conflict of interest. They're saying we want to make sure that services don't affect the patients negatively, but then they can handpick who they want to be on the committee. They could get somebody that's so far medicated that he's not even sure what day it is, and he's on the committee. And do you think that person's going to watch the QIC manual and watching reports? I don't think so. And so that's what concerns me now. I'd like to see it legislated that quality improvement committees are like town hall, and the first thing they're going to say, the objection is, if we had everybody come to these committees, it would slow things down because we need to get some work done. Well, that's not really true. If they had 2 indicators, has there been improvement since the last report? You wouldn't have to sit there and ponder, is this data any good? Is this any good? You'd say, well, we improved 3%, let's move on. You could probably get through 30 reports in a single meeting, whereas right now you can't even get through that in a year. We're looking for improvement. And if we get to one where there is an improvement, then we can have a town hall meeting. Let's talk about why we don't have improvement. I think it'd be so important to legislate it, get it through, that anybody could be a part of the planning, design, execution process in QIC. That's what I think. And none of this back deck stuff, you know, people chosen according to their properties and, you know, desirables.
Yes. I'd like to add that Los Angeles County does have a system for consumers to be reimbursed for their expenses of getting there.
Good.
And so other counties can inquire about the model with Dr. Southard and how that is set up to make sure that consumers are on every part of the process.
Yeah, maybe some of the funds with the Mental Health Services Act, maybe they put in some sort of an incentive program to get people to these commissions and committees.
Oh, one thing that they were talking about to the Mental Health Commission was that the Los Angeles County Client Coalition would like to be represented on TV interactive like you have here for the 8 regions plus the main downtown Department of Mental Health meetings once a month and do it on TV so that they could get questions and feedback. Now, if they did that, then other places in the state could access the website for how it was being done, and the people, mental health consumers, legal people, and others could access it and try to incorporate quick meetings and reports of other meetings into those meetings which are broadcast and disseminated.
Right. Well, I think anytime we can get more coverage, but I think what makes it interesting for people is those 2 indicators. You know, I have those 2 indicators, they get bored, they tune out, you know? And it's very frustrating, like, okay, you gave me 1 indicator, 7% and half consumers. I don't know, is that good or bad? You know, you need the other indicator. What was the previous report like? Recently, I just give you an example at our mental health board meeting. You know, I did the Robert's Rules Order in the first 5 minutes. I said, I would like to hear, I don't know what we're going to hear in quality improvement today, but I would like to hear if there's actually been any improvement on the report since the last report issued. And then I talked about quality assurance, you know, people showing up and looking at things, and this is what we did. That's kind of like a meetings overview. I would like to see if there's actually been improvement. Well, hour and a half later, when they talked about it, she said, well, this is what we did and talked about. And then they went on to something else, and I raised my hand, wait a minute, back up. The question put to you is, has there been any improvement in the reports you've got today? Have you got any reports? And if you have those reports, has there been any improvement since the previous report? That would be quality improvement to me, and that's what I'm here to say. The response I got, well, in the interest of time, I'm just trying to move on if you want to go as a public meeting. So this is why we have manuals, this is why we're trying to get the word out, so we can get people in there asking questions.
Is there any way to say that the meeting and the minutes are supposed to be printed out so that they can be distributed so that you can check that?
Yeah, in fact, I meant to do that to you today. Let me pull this out real quick.
I know some of our meetings are just verbal. They don't keep any written minutes.
No. These minutes are, well, they're supposed to be written down. If you asked me to refer to regulation, I couldn't do that this time. Well, this, by the way, this is my, when I first got the plan, these are all the notes I made on it. I was thinking, man, there's some things we need to talk about on this plan. And that plan was actually work. Okay, that would be the plan. This is what your agenda will look like. This is what they talk about. Some of the things we're going to talk about at that particular QIC meeting. The minutes, these are the minutes. These are like 3 months worth of minutes on QIC. I'll just pass this around. You kind of look at them if you want. Now, the last QIC meeting that I attended, which was about 3 months ago, they were going to work on the QI work plan. And they thought to save us some trouble, they wouldn't give us the plan at all to look at. What they would do is just give us an outline. You see the difference between a big thing about the plan, evaluation report, and an outline. Well, to save us some trouble, and I don't know, maybe I'm overly medicated and I can't read the real plan, so I need an outline. But I didn't want an outline, I wanted a plan. There was some resistance. Why do you need a plan? We have an outline. Trying to make it easy for everybody here. Well, I don't want an outline. I understand, I got a brain, give me the plan. So that was met with great resistance. So don't be surprised if somebody will want to offer you something other than a plan, but you do have the right, Freedom of Information Act, to look at that doggone plan. So, anybody from any other counties or the regions, or Willie, are you all right? Did you leave? Kathi Stringer, are you there? You're gone.
No,
I'm here. Oh, you're here.
We're here.
I said, okay. Do you have any questions?
Nope, we got it.
Did I lose you? You got it?
Nope, we read it.
Okay,
right along
good.
with you.
So are we all done for the day? So it's 5 to 2. Are we going to get done ahead of time?
5 to 3.
Or 5 to 3?
I've got 3.
You got 3. Good. Kathi can't tell time. Let's get that on the agenda.
Yeah.
Okay, well, this concludes our quality improvement training. And again, thank you for letting the network be a part of this with PAI.
Is it available in an email format that I can forward to somebody?
As a matter of fact, there is, and there's a CD. You just, those are all files. Just copy the files to your email.
I just want to send it on, so.
Yeah, I have one on mine that I saved. It's a little older, but it has.
Well,
I was going to say this. The way you can do this really easy. Just stick it in your disk drive, and you know how your email you go attach.
Right.
You just go in there and attach every single file.
Great, fabulous.
We're putting a link on our website.
Yeah, we're gonna put it on our. Yeah, it's one of the.
Yeah, and you know what? I'm gonna
I know, that's what my friend.
The next revision's coming to incorporate in order. remember how it's bouncing around? Yeah. Well, I'm thinking when I did the root cause analysis and I added in the thing about reports, I thought we should put this up front, get people excited about the tools. Okay, I'm here, I'm armed, ready to go. Now, you know, because before I was talking about QIC, what it was, and I was losing people, you know. Yeah. But once you give them something in their hands to use, they, okay, I'm ready to go. Give me something to use. So
right.
I thought that might be a good way to do it.
I thought what was really helpful for me was even just going back to that basic, like, how do you, I mean, especially for a lot of lawyers, they're afraid of math. I mean, that's something as basic as,
yeah, just take it real simple.
How
Take
you
a one,
get
get
the
two.
you know, just so that, but I think we get sort of, I just think about all the things that I get from the State Department of Mental Health. It's really ridiculous data, and they never do a compare, and they get away with it.
They never do the
indicators. And, you know, they'll say, well, we only had, 7 patients.